Hi, welcome to Case of the Day. Another week and another day. And so we're on our 80th case, and this is titled Rapidly Progressive ILD or RP-ILD and Pneumomediastinum, a deadly combination. So 55-year-old with dyspnea in April, first time CT, shows significant disease. And we don't have prior details. The patient had an AVR done. I'm surprised that none of this was documented or diagnosed, or maybe it was and we weren't aware. But um, we can see here reticular opacities, subpleural basal predominance in a 55-year-old. There is a straight edge on the left. So there are enough findings, though not absolutely definite, to suggest connective tissue disease ILD. This patient came for a second opinion, and if you run through the flow chart, these are real lesions. So we have an ILD, it is fibrotic, and there is enough to suggest that it's a UIP or a fibrotic NSIP pattern with many variant features and therefore likely connective tissue disease ILD. PL12 was borderline, and in this clinical context, it is consistent with myositis ILD, likely one of the antisynthetase ILD. In 3.5 months, there was clinical progression of dyspnea, and the patient came on Saturday for a follow up scan, and I saw it today. And if you look at the three images, I've tried to align them, more or less to show disease, and I think it's more the alignment of the right lung than the left. And so you can see here that there's clear progression of disease. One way to make out is to look at the non-involved secondary pulmonary lobule lucencies. You can see here that all these areas are now involved. There is some bronchopneumonia here, a little increased density here, so there is some superimposed infection as well. But there is clinical and radiologic progression in 3 months. So this then is defined as rapidly progressive or RP-ILD. And there's a paper from Dr. Shenoy's group and others from Kerala which talks about this. There are many others. If you go to PubMed and write down rapidly progressive ILD, you'll basically get a whole bunch of anti-MDA5 antibody associated disease. But this patient also had pneumomediastinum, and you can see these specks of air here. This is a MIP in the coronal plane that shows it really well. And this could be due to alveolar rupture or rupture of one of the cysts. And again, if you go to PubMed, you'll find a whole bunch of articles on pneumomediastinum being a really bad prognostic factor in patients who have dermatomyositis and anti-MDA5 disease. So while we don't know this patient's anti-MDA5 antibody status, irrespective, in a patient who has myositis ILD, this combination of RP-ILD, which is a phenotype we should be aware of, and pneumomediastinum plus some superadded infection can prove quite deadly. I mean, literally and figuratively. So it is important to recognize the RP-ILD phenotype on follow-up scans. This is for radiologists. And to investigate for myositis ILD aggressively. It is also important to diagnose pneumomediastinum in patients with ILD. Again, there is a prognostic relevance to this, especially the myositis ILDs. That's the classroom, starts in 2 weeks, my WhatsApp channel. And thank you so much for viewing this. I'll see you tomorrow.